Welcome again to all investors that are here in this afternoon for a new DealÜp of Capital Cell. This week, well, today we have Alexander from OxyPrem, a new company, a Swiss new company that are ready to be a company we launched on Capital Cell. And also we have, well, I was saying Alexander, who is the CEO, and will introduce himself and the project in seconds. But also we have in the public Stefan, the CTO, also Fabienne, the regulatory manager, and Martin Wolf, chairman of the board, and they will have the chance to answer your questions. So, Alexander, if you want to start, we really thank you to be here, and we are eager to know about you and the project OxyPrem.
All right. Thank you very much, Sergi. And again, welcome to all attendees. Thank you for taking the time tonight to join and to get some information about OxyPrem and about what we do. So yeah, like Sergi said, my name is Alex. I'm the CEO and also one of the co-founders of OxyPrem. And today we are here to basically take you on the journey for our upcoming project or product, to put it better, which is called OxyPrem NOAA. And NOAA is here to enable early intervention to prevent brain injury and lifelong disabilities to the weakest of patients that you probably can imagine. Just a quick introduction on our company. So we are based in Switzerland, and obviously we are active in the medtech sector. We were founded in 2018 and have a team of 14 professionals. Yeah, some of them have already joined this meeting tonight. So Stefan is here, our CTO, Fabian, our regulatory manager, and Martin, who is also one of the co-founders, and he is the head of the biomedical optics research lab in Zurich. We are a spin-off of the University of Zurich. After we became the spin-off, we went into a quite large accelerator program that was funding us with 4 million, about 3 years in time duration. And we have our roots in the biomedical optics research lab at the University Hospital in Zurich, which is one of the best institutions for the type of research that we do in the world. Now, of course, we haven't come this way just on our own. We have been supported by very good institutions. So, for example, we've had support by the European Union and also by the Swiss government. And generally speaking, what we do is also aligned to the UN Sustainable Development Goals. So we cover both SDGs 3.2 and 3.4. Which are both included in the SDG number 3, which is good health and well-being. Okay, first look at the problem. The problem that we are tackling is basically that inadequate oxygenation causes brain damage. And it especially does so in premature neonates. As you can see from this picture, preterms are very, very small, very, very fragile, and it happens a lot more often than you think. So 10% of all babies are born ahead of time. And they all share the same problems. The organs are underdeveloped if the pregnancy ends too early. And especially the brain has trouble to regulate oxygen. So that is very difficult for the preterm brain. And the consequences when that does not work are quite drastic, because just 5 minutes of inadequate oxygen levels in the brain are enough to cause permanent damage to the child. The brain is the only organ in the human body that cannot heal itself. Once brain cells are dead, they stay dead. And 46% of survivors of severe prematurity are affected with lifelong consequences, which are moderate to severe disabilities. So that's everything from, missing hearing, missing vision, paralysis, cerebral palsy, motoric deficiencies, low IQ. So there's a big range of problems that these children can run into. And what's been missing so far is the precision and the accuracy that the clinicians need to take a good look at the brain oxygen levels. The technology that we use to do that is called NIRS, near-infrared spectroscopy. It's very nice because it allows you to do oxygen level analysis directly from the brain. It's non-invasive, as you can see on the picture. So this is our NOAA sensor on a newborn of, I think, under 1 kilogram of weight. So really a very small kid. The technology is non-invasive. It uses completely harmless light, and it allows you to do continuous monitoring. So you can use it sort of as a safety belt. You can, yeah, as long as the baby is in the intensive care, you can keep monitoring the brain oxygen levels and react once something happens that you don't want. And on the left side, in the above picture, you can see a little bit how it works. So the sensor basically sends light into the brain tissue, and then it checks what part of the light is staying inside and what part of the light is coming back out. So to put it simply. And it does this in several colors of light. And according to the combination of colors that are coming back and that are staying in, and according to those intensities, the sensor knows about the oxygenation situation in the brain. And the sort of the result that you can draw from this is the clinical teams are trying to make their way to a healthy brain. Okay, this is the #1 goal that they have in this context. And as we said before, if you have too little oxygen in the brain, your brain cells die. That leads to paralysis and all these disabilities. And on the other hand, if you have too much oxygen, that is also not good, because too much oxygen acts as a cell poison. And what happens then is that the children turn blind. And since neither disabilities or blindness are something that you want to have for the rest of your life, it's very important to use this NIRS monitoring to make your way to a healthy brain. Good. Now, you're asking yourself, of course, what's wrong with the existing solutions in this field? There are basically 3 main problems in there. One is that the precision and accuracy, like we said, is not what it should be. And that is mainly attributed to the fact that the other sensors are usually disposable sensors. If you want to make disposable sensors, that means you have to keep an eye on manufacturing costs, that they should be really low. And low manufacturing costs just allow you to put only a limited amount of technology into these sensors. So this is basically a hardware issue. The second is that these sensors have problems with the physiology of preterms. Preterms are very, very complex from a physiological perspective. And other sensors are often originally sensors that were designed for adults. And then the manufacturers were kind of, reducing them in size so that they would fit also on one of these super small heads of the premature kids. But it would not take the physiology into account, which is completely different in a preterm compared to an adult. And now the third point is something that revolves around validation. So how these sensors are typically validated is that they use healthy adult volunteers. It probably could be anyone who joined this call today. And you get breathing masks, and then they reduce your oxygen intake. And then in parallel, they have the sensor on the head, and they check how the sensor is reacting. The problem with this is that they cannot cut off your oxygen intake so much that you would actually have the risk of brain damage coming up because of that. And that essentially means that with this type of validation, you cannot get to the oxygen levels where there could be potential real danger. So in a nutshell, these sensors have never actually seen the really dangerous territory during their validation. So this leads to 2 unwanted effects that you have clinically. One is simply overreading. So these sensors will give you a higher value than what is actually there. And that, of course, creates a false sense of security, because the medical teams think, okay, there is really maybe enough oxygen in there, and in fact, it's not. So this is the first factor. And the second one is that the blood volume also affects the readings. So depending on whether you are having a high perfusion level or a low perfusion level in the patient, which you don't know from the outside, your sensor may give you very different readings. And that is just confusing, right? Okay, so these are the two problems that make life hard for clinical teams when treating these children. And this is the reason why we have come up with our OxyPrem technology. So here you see the NOAA system basically illustrated. This is the entire system that you're looking at. Everything that you see fits in a shoebox. So it's really a small time space-saving system. You have the black part in the front. That is the sensor with the optical part to the left end of it. And then this connects onwards to a small signal processing box. That is this gray box on the right side that is labeled OxyPrem. And then it connects onwards to a small 7-inch tablet that we provide with the system so that the clinicians can get their readouts. And then after that tablet, the data can be transferred onwards to the hospital IT infrastructure. So that's really all that the system is. So we deliberately kept it simple and easy to use, and easy to keep an overview over it. And here again, you see the application example of the sensor on the head of a preterm, and from the hand of the nurse that you see there, you see that both the baby and the sensor are really small. So we are working with very small dimensions here throughout. All right. So what makes the sensor particularly special is that we are covering not 4 wavelengths of light, so which is, the wavelengths would be light colors, as I said before. So typically other sensors use about 4 wavelengths of light. The NOAA uses 13 wavelengths of light, which means that you can generate a lot more data points. And with every wavelength, you can also check for additional substances that are in the tissue under the sensor. So your clinical information picture gets better because you know more about what's happening in the tissue and what is there and what is not there. So this makes a considerable difference in the precision and the accuracy levels that you get out of it. And of course, if you have 13 inputs basically that you can feed into your algorithms, then your algorithms also can be much more complex than when you have only a handful of data points that can go into these. Good. So how does this result in comparison to the other devices? You remember the two problems that we identified before, with the overreading and then with the dependency on the blood volume. So here is basically how existing sensors are acting in this respect. You see that all of them are sitting above the ideal green line. So on the green line, basically, this means that the oxygen that is actually there will also be displayed on the device. So you have 60% actual oxygenation, and then your device will show you 60% and hit that information spot on the head. But as you see, all of these curves are sitting considerably above that. So you have the overreading effect in there. And you also have this effect of the blood volume affecting the readings. You can just optically see that the 2 red lines that are the measurement lines for the other devices, they go apart from each other. And now, in comparison, here you see the results that are being generated by the technology that OxyPrem has developed. So what you see, first of all, it fits really well, really tightly around this 45-degree line, the green line, which is kind of the ideal measurement scenario. And also you see that the red lines, which would be high blood volume and low blood volume, they don't open up. So it's a lot less prone to error coming from the high or from the low blood volume. So if you, I mean, that was a lot of technical information. Sorry about that. So if you basically take a step back and just look at this visually, you can see just from the how the picture looks like, you see that the OxyPrem readings are much more homogeneous and much closer to each other than it is the case for the other sensors. So this would be our technological edge. Now let's take a step over into the hospital. Who actually benefits from OxyPrem's technology and how? So the value proposition to physicians is pretty clear. It's that they get the precision and the accuracy that they were missing. And to put numbers on that, while other sensors may give you false positives or false negatives about 1 in every 6 readings that they get, this is the case for OxyPrem technology in only 1 in 200 readings. So that is a considerable, that is a considerable difference that directly translates into precision and into accuracy. So physicians are looking at that. They're going to be happy with this. A second group, which is maybe even more important than the physicians, is the nurses, because the nurses, they do the heavy lifting. You know, they do every day, they interact with the patients. They get everything done clinically. To them, it's important that you have usability, that you have clinical utility, and that you don't disturb the patient if you don't have to. And what we did in order to do that is that the sensor is really soft, it's really gentle, and it was really tailor-made for these preterm children. Also, for example, to give you a little anecdote, you don't glue it to the head. So other sensors are often sticky, and then you stick them on the skin. But what happens then, because the skin is so soft and so thin in these kids, when you take the sensor off, you have a pretty good risk that you also take some of the skin off with the sensor, which is why OxyPrem uses non-adhesive fixation, right? We don't stick anything onto the head of these kids. And of course, for the nurses, there is a trust element that gets created when they see that it's easy to use and when they also see that the clinical utility, so that the precision and the accuracy are really what they are looking for. All right, the third group, a bit less romantic, if I may say, are the finance departments. They are, of course, looking at the costs. For disposable items in the hospital, it's always the same. You have to keep rebuying them because you keep using them over and over again. And in the case of these oxygenation sensors, they typically are good for 3 days. And after 3 days, you need to, put the one sensor away, throw it away, and then get a fresh one. So every 3 days, they have to pay. Now, in contrast, if you use a reusable system, which would be OxyPrem NOAA, then you have about 40% in cost savings in typical use scenarios in the hospital. And of course, it's not only the cost savings, but also we create a considerably smaller amount of waste because of that. So in a typical year, you would use 100, 120 of disposable sensors, which you would not do if you have a reusable device, because then you can always use this one. Fourth group, I think you've guessed it, are the families, of course. They are just scared and nervous about the health of their children. To them, at least, it gives a certain degree of comfort if they know that the medical teams are using kind of the best tool in the toolbox that they can get. They will still be nervous, they will still be scared, and maybe some of you who have joined tonight have family history or so in this field. So you will know that the parents are still going to be very nervous, but at least if they know that the medical team has all the technology that they can get, that would be comforting. All right, quick look at the body of evidence, what is behind OxyPrem. On the right side, you can see pictures of actual application of our first device series in hospitals. And when I say in hospitals, I mean that the first device series that we launched a couple of years ago has been used in 38 neonatal hospitals across 12 countries. We've had well over 300 patients being monitored in normal clinical care conditions. And also because OxyPrem has done quite a big part of research before the company was founded, there are 13 clinical trials and 17 publications that are supporting what we do. And then, of course, hospital-wise, what is important are the testimonials. So voices of customers, voices of users, we have collected some of these here. I don't think it's necessary to go through all of them, but you see just from the highlighted sections that the feedback that we get is very encouraging. I'll just leave this here for another couple of seconds so that you can take a look for yourself. Okay, now let's get out of the hospital and let's get into the market. So our bridgehead market is clearly neonatal and pediatric application. So every year there are about 45 million patients globally that are in need of brain monitoring. The largest group of these are, of course, the preterm born children. Then the question that we have to ask is, can all of these children go to a hospital? And this is, of course, not the case depending on where you are in the world. So you end up with an addressable patient group of about 10 million every year. And now applying the price that the hospitals have to pay to get this type of monitoring, this is on average $200 per patient. Of course, it's going to be more in developed countries. It's going to be less in less developed countries. But generally speaking, the average expense is about $200. And that means that addressable patients, 10 million times $200 will give you a market size of about $2 billion every year. And no surprise that the largest global incidence of premature birth is in India and in China, just because of their sheer population size. Good. Extension markets, things that we can look beyond neonatal and pediatric, are, for example, to stay with brain monitoring, but to do it for adults. So that will be another $3 to $6 billion market on top. The second one is adult cardiac surgery. So we have over 1 million cardiac procedures in the US and Europe every year. So that's also a big one. And the third one is vascular medicine. So for example, if you have a peripheral arterial disease or you have a diabetic foot, these are all applications where it's also very relevant to know up to what point is the tissue well oxygenated, well perfused, and up to what or after which point it's no longer the case. And these are, of course, also very attractive market extensions due to population size and aging population and all these things. Good. One look maybe at the flow of money. How does it work financially? So in most DRG-based systems, the health insurances pay the hospitals per newborn that the hospital gets. And the rule there is that if you have a very small, very tricky newborn, you get more money than if you have a late newborn, which does not cause many problems. The more difficult the patient is, the more money the hospital gets. And in the end, the hospital is able to use this money as they seem, as they see a good application for it. So they are flexible to do that. And of course, then what they buy is they buy the solutions that resolve their pain points. And that takes us back to the value propositions that we've covered before. So OxyPrem covers the value propositions well that these parties are looking for. And therefore, the hospitals then basically buy the products from OxyPrem or from distributors. We're also working with distributors. And having said that, there is the opportunity to buy or to rent the equipment, depending on what the hospital prefers. All right. One topic that is also relevant is IP, intellectual property. We have filed 8 patent applications in total. I mean, this is a busy slide. You don't need to read everything, but if you see in the column that is called stage, you see that the first 3 patents that we filed are already granted in at least some jurisdictions. So we have one that is granted in the US and China, and 2 more patents that are granted in Europe. And now basically we're in the stage where these patents get granted, one by one. It takes time, to go back and forth with the patent offices, but now it is happening. Good. Quick look at the team. So Stefan, Daniel, Martin, and me, we co-founded OxyPrem in 2018. Everyone besides me has their roots deep in the technology. So Stefan, Daniel, and Martin are all coming from the background in the biomedical optics lab. On the board of directors side, we have 3 very, very good directors. They're all based in Switzerland, and they all bring different types of medtech experience to the table. But the main part is, of course, the core team that works on OxyPrem every day. So we could do nothing without everybody involved here. And we've got all positions covered that you need in a medical device company. So we've got sales and marketing covered. We've got project management. We've got regulatory and quality, and we got the post-market surveillance and vigilance side. So all these roles are used internally for OxyPrem. Also, of course, we have an R&D section, being a tech company. So very good tech team behind there. And the supporting roles are, of course, there in IT and operations, which are also all of them in-house. We also have a clinical advisory board with 4 clinical experts, one from Poland, one from Switzerland, one from the UK, and one from Greece. And we have regular meetings with them to align on the clinical strategy. So it's good to stay close to the clinical field. All right, so we got to the point where we can sum up. From what you've heard so far, the clinical request for the next generation device was at the beginning. Then, all the prototypes were done. We founded the company. We went through some non-dilutive funding that helped us get further. And then we entered the accelerator, and also we won one of the most important startup competitions in Switzerland. Then our first series of devices was kind of the technology launch. So this was called OxyPrem 1.4. You see it here on the screen. That was basically meant so that we could prove that it's possible to make such a device and to release such a device into the market. So this one had CE mark and everything. It's a fully approved medical product, but for us, it was basically to show that the technology could be brought to market. And where we are now, and also where you are coming into the picture, is the commercial launch. So the NOAA will have the new CE mark under the new MDR system by the EU. So the technology is very, very, very similar. We just made the sensor smaller so that it fits better on super tiny babies. And this one we can also freely manufacture basically as many as we need. And on the business side, of course, what we want to get is we want to get commercial traction. We want to build the partnerships, and also we want to extend the regulatory and the IP side. The funding round that is currently open. So we started this last year already. We raised about 1.4 million. Now 2.3 are coming on top. And the value creation points that we are looking at are to finish, of course, the CE mark for the NOAA, then to launch it into the market, and then to have sufficient runway so that we can keep discussing with our potential acquisition partners or strategic partners, business partners, to then go down the line of exiting the company at some point to a larger partner. The use of the funds that we are raising are, well, yeah, I think it's quite obvious. So we have a team of 14 that needs to be covered. The CE mark is going to cost money. Production for the first commercializations will cost money, and then of course we're going to have launch costs. Two side remarks here. Looking at the current cap table, we have about 63% of shares still with the team. 21% with university, and the rest is just somewhere else. And on the funding side that we've gotten until today, you see that in the small box on the bottom right. So far, we've raised about 10 million in funding from various sources, basically. All right, that would be it from my side. Thank you for listening. I think I took about 25 minutes, maybe a little more. I hope I could answer questions already beforehand. If not, please feel free to ask me. Also, feel free to ask Stefan, our CTO, if you have a technical question, Fabienne for regulatory, or if you want to speak to the mastermind behind everything, who started everything in 2008 or 9 or so, that Martin would be a good addressee for that. Thank you.
I think that Alexander, with all these good words, we can end the webinar. Thank you very much to be here, to all of you, the investors, but also the team of OxyPrem, and have a nice evening.